Thank you very much again, and many thanks to Vertex for supporting the talk. And actually, it's great pleasure to follow Dr. Abdullah Jeffrey and make it as a whole a package of the gene therapy journey. And today we'll talk really about some practical stuff that will be raised, and including inclusion criteria and many other related, and the story of the first patient that received gene therapy in the kingdom. So first of all, we'll talk about a little bit of introduction and the journey in National Guard to be accredited as a center, and then we'll talk about the progress as well. This is a repeated slide about the burden of the two diseases that sickle cell is so common, and between 60 to 100,000 sickler in the country. And for thalassemia also it's estimated, of course, less than that, between 5,000 maybe to 9,000, or a range maybe a little bit lower, as a transfusion dependent. Now, as mentioned earlier, the candidate of curative therapy and severe form is about 20%, 15 to 20% of the patients. And this slide I've already shared earlier with the percentage of stem cell transplantation. If you go back on the previous talk and how patients originally, and when this was published as a guideline, for example, in sickle cell patient, who to transplant, and it was dated in 2019, you will see it goes based on the severity, and if there is a donor and there's a matched sibling, then you go for a transplant. Especially if it's mild disease, then it's a question elective you could consider. If it's severe, you will go for it and push for it a little bit more. But if you have a severe disease and you don't have a donor, then you go for the alternate donor. So at that time, the talk was about putting patients on trials for haploidentical transplantation or gene therapy. Now, if we look at recently and how this got evolved after the studies been elegantly illustrated by Dr. Abdullah, and all the outcome in regards to the exa-cel, it was FDA approved, or like it was approved by the UK earlier, and then in the FDA by December 2023, followed by the Saudi FDA in January 2024. Now this is a big move because it is changing the landscape and the movement and how to approach those patients, and it opened a track for many patients who are suffering. And as illustrated earlier, using CRISPR-Cas9 gene editing approach in that situation in exa-cel is just to direct BCL11 and knock its function, in other words, and remove the repression pathway, and then hemoglobin F will be raised. Now this pathway in sickle cell, you will go up to 40-50%, but in a thalassemia patient, you'll probably be 80 or 90% hemoglobin F, and then you'll be transfusion independent. And those are certain of the endpoints that was talked about, and it's already been illustrated very well about the value of hereditary persistent hemoglobin F and whether that could alleviate the vaso-occlusive crisis in sickle cell. So from there, the work to transfer and go through that kind of treatment and cellular therapy in the institution started earlier, after the fact accreditation, but late in 2022, we started to work with some quality work between the groups in the adult hematology stem cell transplant unit, and the pediatric, the stem cell lab, and the apheresis team, and a lot of support both ways from the Vertex Pharmaceuticals, as well as the administration support and the K-Mark, because there are a lot of interactions between the groups. So as soon as we were almost there, we knew that it's going to be approved by the Saudi FDA sooner or later. And then as soon as then that multiple visit mocks has been done, until we got the approval to go through the journey, as you saw then illustrated earlier, from the collection to transferring the product to bringing, taking care of the product, retransfer it back, and then later on conditioning the child or the patient and infusing the cells, and follow up after that. So the first patient was collected in February is a transfusion-dependent thalassemia patient, a 12-year-old at that time. Now he's 13, almost. And the first sickle cell patient was collected by our adult colleagues in March as a starting point, who requires multiple collections, because the difficulty in sickle cell and collection is more than the thalassemia. While in the other way around, we think, and as per illustrated in the data, complications for thalassemia during conditioning and after conditioning, like VOD, is higher in thalassemia patient and need to be worried about or be careful about, similar to transplant patients. Alhamdulillah, 14th of July, the first patient was infused, but we'll come into details and describe you certain things during that time and how we try to select those patients and who are the candidate, because that was a main question from the audience. So in the hospital, we had also multiple meetings, and I believe a lot of support and a lot of discussions, and it will be also with the National Collaborative Group later on and see how things will go. But we elected at the beginning to follow the SFDA approval. So it has to be an age above 12 years. So 12 to 35 is our criteria. We currently, the subjects are severe sickle cell. So, and we define that by recurrent VOC more than 2, per year in the last 2 years, requiring hospitalization, despite using hydroxyurea and other things. So indications that it is severe, and also recurrent acute syndrome as one of the main indications, or severe disease that's causing ICU admissions and frequent exchange. Now we have to put in mind, because it goes through certain things similar to transplant. Patient has to have a good performance status, good Lansky, good performance, and could tolerate the process, the whole process. In addition to that, we've put some help, or like a kind of exclusion criteria at the moment. All what I'm talking about is dated today, so maybe it may change in the future, and there are a lot of things that change depending on the outcome and many other things. But if we have available, as mentioned by Dr. Abdullah, that a match donor, 10 out of 10, will go for a transplant rather than a gene at the moment. Other exclusion is a prior transplant, prior myeloablation. So, this is one of the things, at least at the moment. And a clinically, of course, significant active infection or so, that will make the patient at high risk during the procedure. Now, there are other things that very logic, like inavailability of blood product and severe aluminization, that you cannot have some transfusion during the conditioning or post-conditioning regimen time, or patients like in the study who have severe chronic pain in sicklers, that you sometimes more than 10 unplanned hospitalization, that you worry that it's not only about the sickle cell and the vaso-occlusive crisis, but it's more of a chronic pain that may affect the outcome as well. Now, I put in red two things, and those, we need more data about it, and at the moment we are not going there yet. Now we can't say that you cannot do it, but at least in the studies and in the inclusion criteria in the study, those patients were excluded. So patients logically with persistent fetal hemoglobin, especially in the eastern region, they are needed to be studied further. The presence of vasculopathy, particularly Moya disease, need to be also tackled more to study before going it and putting it as a standard of care. The other exclusion or things that you have also to be careful about, similar to a transplant, severe advanced liver disease, someone who has cirrhosis, or a GFR less than 60, or a very severe lung dysfunction or restrictive disease that you cannot go for busulfan. So there are other things that is, heart disease. So there are things that is similar to transplant that we cannot proceed with gene therapy at the moment. On the other hand, if we look to TDT patients, transfusion-dependent thalassemia, we also have to make sure those patients really transfusion-dependent thalassemia. So they have a lot of transfusions, and based on we put the criteria that usually is for beta thalassemia major, what we called in the past, or intermediate that are on very regular transfusion. And if you see in the study, there some of them were beta 0 and some of them were beta plus. Also similar to sickler, they have to have good performance status, good organ function. Similarly, we particularly focus here on iron overload in thalassemia patients. We also have to focus on it on sickle, but in thalassemia it's more obvious. So looking at the cardiac and the liver MRIs, we have put the function, if it's less than cardiac T2 star less than 10 milliseconds, then this is kind of exclusion. We also mentioned the other liver dysfunction, etc., as not fit for the conditioning. And if the liver iron concentration is more 15 milligram per gram dry weight on T2 star MRI, you need to be cautious and bring it down prior to conditioning. So similar to sickle, the presence of HLA matching. The others are very similar. Other exclusions like significant bleeding disorders, active malignancies, or history of restrictive lung disease, GFR less than 60, and active severe viral infections, HIV, etc. The other part also that was already raised is how to collect those patients. And GCSF is something that, as mentioned, it's not usually used or deemed as contraindicated in the protocol because of the propensity in sickle cell patients to cause a crisis. Now, we know that CD34 cells, it get lower by age. And if you are a sickler and you have a lot of crisis, etc., you probably have an abnormal bone marrow. So the bone marrow will not produce as much as you would expect. So to prepare for mobilization, and this is one of the major challenges because we are reaching around 8 patients, mainly in adults and 2 in pediatrics at the moment between sickle cell and thalassemia. There are preparative things that you would do prior to doing that. I would start first with the sickle cell because it's first here and it's the most common in our country. So those patients, there are certain things like stopping hydroxyurea around 8 weeks prior to the collection. And then you start those patients on those who are not on regular transfusion, and most they're not because you're not taking the stroke patients. So you will initiate exchange transfusions for those patients. You want to keep the hemoglobin between 8 and 11 and do exchange. And then you do the last one during that period, 3 days prior to the collection. And then you give Prelexivir for 3 consecutive days, and each day you will collect. Prelexivir in sickle cell, you give it around, in our protocol, 3 hours prior to start the collection time. And that you don't want to miss the peak of the collection because it has been seen in the studies, and in the original study it peaks around 4 hours, 4 to 5 hours post the giving Prelexivir. The other thing is you try to avoid those patients from crisis and acute syndrome because in the studies and per communication, some of those patients you start them on GCS, on Prelexivir and mobilization, etc., and you don't want them under the stress to get a crisis. The good thing, you already have done exchange transfusion, etc., so that's already helping. But on that, some protocols in sickle cell, people would give anticoagulation prophylaxis. So whether enoxaparin or aspirin, it depends on the center preference, and it's not mandated. Those all helps to motivate and increase the yield of the collection, because you want to reach around the maximum that you could get. The target is around 15 to 20 million. If you reach it, that's good, because 15 to 20 million per kg of CD34 is not easy to get. And our colleagues in the apheresis and stem cell lab, each cycle, each time you get collection, it's not one day collection. You do the first day and the second day. The third day is a backup in the first cycle. We call it a cycle with 3 different collection times in the first attempt. So as mentioned, it's usually the range between 1 to 6, and the median is around 2 cycles is needed for any sickle cell patient. And from our experience, they are variable in the adult team. Some patients are needing more cycles than the thalassemia patient, because we saw the difference. So in thalassemia, it's the other way around. They are already receiving transfusions because of their underlying disease. They are not on hydroxyurea. They can get GCSF. So you mobilize them like transplant patient. You start with GCSF 4 days earlier. The only thing you need to put in mind, if you have a splenectomized thalassemia patient, then you need to adjust the GCSF to once a day, or like half dose, so 5 mic per day instead of the 10. And we give the Prelix for 4 to 6 hours this time in thalassemia patient per protocol, and usually they require 1 cycle. The average is 1 to 4, but 1 is usually enough. And with our 4 patients who are collected, all got 1 cycle. So a lot of work early AM apheresis, because the cells need to be shed and go in a fresh daily with a flight to the manufacturing or treating facility in Europe. And that logistics needs to be really arranged, and thanks to all the people who are involved in this process. Now we can give you a little bit of more of a clinical outcome for the first patients that was done in the pediatric, who is a 12-year-old and now 13-year-old. He's a beta thalassemia patient who ended up by regular transfusion program lately every 3 weeks, has got iron overload, and referred to us for transplantation. This patient unfortunately did not have a match donor, and neither match unrelated donor, and started to accumulate iron. The ferritin was in the 3,000 range plus on iron chelation, and was following rigorously after that referred to us for transplantation. So we received this patient in February, collected him, and one-time collection was enough to 1 cycle to ship the cells, and we got the great news after that cells are enough, and the quality checked has been give us a green light that there are a lot of work and quality to make sure that the cells are adequate and of good quality. So once we received it end of June, we started the patient on conditioning regimen. But before that, we reassessed the MRI to the T2 star again. So the iron concentration went down from 10 to 6 milligram per gram per milligram dry weight. And the cardiac MRI was always good, above 30 milliseconds with a good ventricular functions. The ferritin was actually in the range of 2,000 or so. And the dyspheral was stopped. So we had actually, during the time of manufacturing, we were able to intensively chelate the patient with differiprone plus like dual therapy with differiprone and dyspheral. And we made sure that the pulmonary functioned well. We give the 4 days busulfan with Q6-hour doses. You have the options of doing once a day or Q6 hours dosing. We are more used to Q6-hour dosage. We have increased the dose of busulfan from 0.8 milligram per kg per dose to 1.1 milligram per kg per dose. So it's like total 4.4 milligram if you give the once a day dose. And we targeted around 70 milligram per liter. Now the original study targeted between 80 but the data of the study for the Q6-hour dosing, 70 milligram is acceptable. This is the big bucket where you have the cells, and those are the 3 vials that we received. So it could be 1 vial, it could be 9 vials. We have received 3. We had on them 12.2 per kg, millions per kg of CD34 thawed, infused, day 0. And during the pre-engraftment period, so in 14th of July until the engraftment, patient had the usual neutropenia, cytopenia, mucositis, and the patient had a mild VOD, but a little bit late. Everything was shifted. It's like the myeloablative transplant. It's like 7-8 days after you see the drop of the cells, like reduced intensity and other, but it's with busulfan. So we started to see the drop after day 7 or 8, and we were like, is it working? Like the chemotherapy, it's always there, scary for the first patient, and especially patient accepting to be the first to be treated with such therapy in the center. Now, for that reason, they put the patients on defibrotide, and the patient was tolerating that, and diuresis, and patient recovered from that very smoothly. Neutrophil engraftment was a day plus 25. Last transfusion was day plus 32. It was before, but they transfused before I told them. It was like 8 point something, like 0.9, the hemoglobin. I thought we should just go to 8, not 9 as a threshold, but anyway. We added 7 days for the platelet engraftment. And the patient was discharged. And the last transfusion was given, that PRBC transfusion was around day 21 or so. So it's around more than 6 or 7 weeks now from the last blood transfusion, where the patient were receiving it every 3 weeks prior to the procedure. Interestingly, the hemoglobin F we wanted to check because that's the marker that we are looking at. So at day plus 52, it was 31%. Beginning of this week, on Sunday, was 42%. We're seeing it nicely coming up. And the patient is being followed closely. We are hoping that we will resume iron chelation in a while. At one point, I did the ferritin. I saw the same curve and I got scared after like a transplant, or like it went up to around 10,000 plus. So it's an inflammatory marker. It's nothing, but it is exactly the same as the figure showed by Dr. Abdullah, that there is a peak and it's coming down. Really, it is a benefit and risks, and the difference between gene-edited and stem cell transplantation or allogenic stem cell transplantation, because these are autologous edited cells, is the conditioning regimen, the type of transplant, the GVHD risk, post-transplant care, return to work or school, quality of life. All these are factors to be considered, and also the number of patients, the cost, and many other things. We know there is no GVHD. We know donor availability is not needed in gene therapy. And so far, from the few numbers of patients that have been published, graft failure is not a big issue, but long-term follow-up is needed. We have to keep in mind also transplant-related complications, whether with gene therapy, with the current busulfan-based conditioning, or in the future if it's going to change, because that may play also a different role in choosing, infertility risk, and the risk of disease progression with age or long-term follow-up and the unknowns. So to conclude, we know that allogenic and gene-edited therapy are changing the natural of sickle and thalassemia patients. Gene-edited therapy has the potential to overcome many limitations with transplant, like lacking a suitable donor, a GVHD, and the need of prolonged immunosuppression, and easy go back to work and school. Very promising experience for the first patients in regards to mobilization and treating. We still did not infuse the first sickle cell, but also we are willing and to see how that goes. The limitation of gene editing therapy studies are very clearly. There's a small number of patients around the world who have been treated so far in clinical trial and a shorter follow-up, and really a national approach and support and collaboration is really warranted between all the aspects. Let's remember, there are many corners here: the patients, the clinicians, the laboratory services, the logistics, and the decision maker, the Saudi FDA, the Ministry of Health. There are a lot of people that are working together, hopefully, in the future for a better future to lead this particular part in the country, and contribute to the international community, and for those patients with hemoglobinopathy who are really usually suffering in many different areas in the world. Before forgetting, this is a barcode. Please, if you could screen it, you could also evaluate the session. It would be great. And thank you again for having me here for our second talk, and I'll be happy to take questions.